Assalamu alaikum. This is Naveed Khan from Shaukat Khanam Hospital, Lahore. On behalf of the management of Shaukat Khanam Memorial Cancer Hospital and Research Center, I welcome you for the today's webinar on breast cancer pathology. Our speaker for today's session is Dr. Mariam Hamid. She is a consultant pathologist at Shaukat Khanam Memorial Cancer Hospital and Research Center and fellow Royal College of Pathologists. Today's session will be of around 45 minutes. After the session, you can have the questions through the chat box. So all the participants are requested to write the questions in the chat box and Dr. Mariam will answer after reading those questions. Now I would request Dr. Mariam to please start her presentation. Dr. Mariam, please start with it.
Assalamu alaikum ji. Thank you, Mr. Naveed. Let me share my screen first. Ji, Naveed sir, can you please confirm that everyone can see my screen from here?
Yes, Dr. Mariam, your screen is visible. No, it's fine now.
Thank you. Assalamu alaikum ji and good morning, and thank you everyone for attending this session. This will be a short session, but I will try to make it as informative for you as possible. Let me just clarify that I will not be using this session to teach you pathology basically, but we will share with each other the concept behind the advancing current managements and how the breast cancer pathology is updating itself according to the new requirements for the rapid advances that are coming up in the breast cancer management. तो बेसिस मेरा जो इस पे एम्फसिस होगा वो ये होगा कि एज अ radiologist, as a surgeon, as an oncologist, and as a pathologist, how we can offer our best management plans to the patient of the breast cancers. A little bit of introduction for me. I have been trained in Shaukat Khanam Hospital for 4 years, and then I worked with Professor Shusha in the breast cancer pathology at Imperial College, and I have done independent breast MDTs as a consultant in the Buckinghamshire and Royal Berkshire NHS Trust for a few years. So the agenda of today's meeting is that we will be dealing with the optimal tissue collection and tissue processing guidelines, which are highlighted in the new ASCO guidelines of hormone receptor and HER2 new assessment papers. We will talk a bit about tissue banking, PD-L1 staining, just to give you an outline that what we offer and how is it changing rapidly in the new scenario in cytohybridization, BRCA mutations, and what further molecular testing is being recommended these days. First of all, I'll just start off with, like any physician that in our community, for the pathologist, the forewarned pathologist is the forearmed pathologist. The more information we have from you before you send the specimen, the more informative report we can get out to you as well. So it is like in any field of the medical, we need to be well informed to be able to perform the optimal duties. Now, so this is the diagnostic tissue, and it is the most precious commodity that we have. As you all understand, that the tissue that you sent us as a diagnostic biopsy, that is the initial biopsy before the treatment even started, that is just for the purpose of diagnosis, that is the most precious biopsy. And it is often in the form of either incisional biopsy or core biopsy though. So you realize that the tissue is really limited here. But this little tissue is very important because it has to go for the histopathology reporting. it determines that if the biopsy is malignant or benign. It goes for the diagnostic immunohistochemistry, because we have to realize that you realize that sometimes the case is not that easy, and we have to prove through the immunohistochemistry that it is a cancer or non-cancer. Is it a benign? Is it a DCIS? So that is also important. And again, if it turns out to be cancer, the hormone receptors have to be performed on this tissue block. The FISH has to be performed on this tissue block. If the HER2 becomes 2+, BRCA testing, PD-L1 testing, other molecular testing, all of that has to be performed on this little piece of tissue. So this tissue is a very important thing, important piece of information that a patient will have. And it is a precious commodity because as it is a small tissue, so the pre-analytical factors that can change the results of these tests can be managed on the small tissue, and they're difficult to manage on a bigger tissue piece. And I will explain it to you later how, what I'm talking about. So this is the type, these are the types of specimens that we receive. It's core biopsy, incisional biopsy. We receive unoriented lumpectomy, wide local excisions, mastectomies, excision of metastases, and cytological specimens. Just very briefly and very quickly, I'll just tell you that what we do with the specimen that has been sent to us by you, and how many steps does it take to finally reach the final diagnosis and up to the MDT discussion. The specimen removed from the body is placed in 10% buffered formalin at the level of this surgery. Surgeons usually place it. And if you're an interventional radiologist, you must be aware that when you send us the specimen, you put it in the formalin. So the time that specimen is removed from the body and it's placed in the 10% buffered formalin is very important, because that is the ischemia time. And the lesser the ischemia time, the more better quality of the tissue we will have for all the molecular testing. Because you realize that no matter how much molecular testing we advise to the patient, how much new molecular testing or other testing come up in the future as well, the tissue quality remains the key factor that will affect the results of these tests. If your tissue quality is not good, we will not be able to get good results from whatever test we will perform, and it doesn't matter how much expensive machines we use to perform these tests as well. And then from that 10% buffer formalin until the specimen comes to us in the gross room and we do microscopic examination and we do the sectioning and blocking of the specimen, this is called the fixation time. Again, these two times are very, very important in regards to the quality of the specimen. And again, then the processing, microtoming, slide preparation, then consultant review it and perform diagnostic and prognostic immunohistochemistry, then reporting of the reports, and if the HER2 FISH is required, that is done, and the case finally goes for the MDT discussion. Now, according to the ESCO guidelines of hormone receptors that came in, I think, 2020, they required us, and also from the College of American Pathologists, they required us to tell us if the cold ischemia time and fixation times are according to their advised criteria or not. And they require it to be present on every ERPR report that we issue. So we have added this little column in our report, and you must be seeing it more often now. So we have to take either it meets the requirement, it does not meet the requirement, or we cannot determine it. Just again, a repetition that what is the cold ischemia time? It is the time specimen is removed to the time it is placed in the formalin, and the recommended time is 1 hour or less. Similarly, fixation time is the formalin is added to the specimen and up to it is cut up, and the recommended time is 6 to 72 hours. So if the specimen is fulfilling this criteria, we take the meets requirement. If it does not, we take do not. And sometimes what happens often is that we do not know the time the specimen was removed from the body, and we do not know what time the formalin was added to the specimen. So then we take the cannot be determined category and we write that ischemia time cannot be determined. However, we try to put the fixation time in it as well, because most of the time the date of the surgery is written on the requisition form. So from the date of the surgery, we try to calculate the fixation time, and we make sure that it does not exceed 72 hours. It cannot be done before 6 hours because obviously it takes time to reach the lab. But we make sure that it does not exceed the 72 hours bracket that is recommended by the ASCO guideline. Again, the importance of ischemia time and fixation time have been again and again emphasized in different papers, especially for the PD-L1 testing. This is the this study that I'm sharing with you. It is validation study of the PD-L1 stain, and in this particular testing, they did not even include the specimens for the validation, which had the ischemia time of less than 30 minutes. So that is how you know that how important it is to have the ischemia time. I'm sure the interventional radiologist must not be having any difficulty in taking the core biopsies, because in core biopsies, as you must know that, as you all know, that the tissue, as soon as you take it, you put it in the formalin filled containers. So the ischemia time is just within seconds. So you see, that is why when I say that the initial biopsy is the very important, precious commodity for the patient and for the surgeon and for oncologist, because that is the tissue that has the best quality that patient will ever have from that tumor. Because when you do realize, when in excision specimens and all that stuff, the processing time, the time this formalin is added to it, and obviously it's an intact specimen, it will take, formalin will take its time to reach the inside of the specimen and reach the part of the tumor. And obviously, no matter how much we try to do it, there will still be some issue with this ischemia time and the fixation of that tissue. So we did an internal audit of our in-house specimen, that the surgeries were performed in-house and the core biopsies were performed in-house. We did an internal audit, and what we found out that in the all core biopsies, the ischemia time was 10 seconds. Fixation time for all the specimens there was 100% compliance. There weren't any specimen which were being grossed before 6 hours or more than 72 hours. However, for the resection specimen, again, we were feeling that we were not being given enough information on that. As you can see on this container, that the FA is formalin adding time. There is a formalin adding time written to it. In our hospital, what happens is that surgeons don't put the formalin in their theater. They perform the surgery, keep the specimen there, and then transfer the specimen to the lab, and the lab themselves put the formalin in it. Now, in this workflow, what was happening was that, because obviously lots of surgeries are going through at the same time, so what operating theater staff was doing, they were keeping the specimens there, and the specimens were being transported in bulk to the pathology department. So that was making it difficult to meet the criteria of less than 1 hour for the ischemia time. So what we proposed the workflow was that the time of specimen removal was noted on the container right at that time when it was being done. And if there is, if the operating room nurse feels that any of the specimens might take longer than it is needed, longer than 1 hour to be transported to the lab, they will expedite that specimen first and make sure the formalin is added through the pathology department, and then they can take back the specimen and they can proceed through their routine as they do usually. We also started, made a stamp on our own work orders, which included the specimen removal time, formalin add time, cold ischemia time, total fixation time, and the time of processing. In this manner, it was easier for us to do the audit as well. And it was easier for the techs at the table, at the reception table, to add on all those times and make sure. Here you can see by adding that, we clearly see that this specimen is exceeding the required time for the cold ischemia time of 1 hour 30 minutes. So after the audit, we did a re-audit after implementing, and you see the compliance increased up to 78%, and fixation time remained up. The compliance was 100% throughout. Again, the quality of the formalin is very important. 10% buffered formalin is very important, and as you can see that this on your screen, the picture on your extreme left is the optimal fixation. Here the cells are visible clearly, stroma is visible separately, necrosis is visible separately. However, when the formalin was weak, the middle picture shows that all the glands are just haphazardly placed, and the cells within the ducts of the breast are sorted within the middle of the ducts, and it's very difficult to assess if this is a benign breast or a malignant breast or a DCIS, because you can very well see that although they are demarcated, but you cannot see the cell outlines, and you can only, the stroma is visible and the cell outline is very, very rudimentary. And it's sometimes the diagnostic immunohistochemistry works on it, but most of the time even the diagnostic immunohistochemistry doesn't work on it, and we are unable to identify if this is a malignant or a benign for certainty. And unfortunately, then we have to advise the repeat biopsy to be more certain, because it's not just about the diagnostics, it is also because ERPR has to be performed on this, molecular testing has to be performed on this, and if this tissue is not even sustaining the diagnostic immunohistochemistry, then the results of the hormone receptors and molecular will not be much reliable on such kind of a tissue, and we often advise repeat biopsy on such day. Then the picture on the complete right is autolyzed tissue. Here you can very well see that it is all diminished and no cell outline, no nuclear details is identifiable, and obviously no reporting is possible on such tissue. This is our grossing station. We have 7 of these stations which work from 8 a.m. to 8 p.m. in the evening, and take the workload of around 300 to 350 specimens a day. Okay, one more thing is that while grossing even the small biopsies, it is so important to retain the tissue for further testing. So even if it's a core biopsy, it's not easy to maintain the core biopsies, because this is a picture of a block when it is embedded in a block. So each time a test is performed, the tissue becomes less. Eventually it becomes the tissue thickness becomes less and less and less, and eventually it will not be possible for performing more tissue. So what we have started doing is that the core biopsies that are sent to us are put separately in the cassettes, so that we have more tissue available at the end of the day for the study, for further studies. For example, in this case, which are you're looking, you can see a few slides, and there are almost 8 to 9 cores that we received. So what we did was we put 2 cores in each cassette and then do levels on it, so that more tissue is available for microscopic examination. That is, in this way, when we use diagnostic, if the tumor is coming in all of these cores, we will use slide 1, block 1, for diagnostic immunohistochemistry. We will use block 2 for the prognostic immunohistochemistry, hormone receptors. We will use block 3 for the molecular study. We will use block 4 for further molecular studies if needed in the future, because sometimes you know that people come to us after 4 to 5 years and they want to perform certain tests on their initial biopsy, like people used to come for the Oncotype DX test, they wanted a block, and sometimes we did have them, sometimes there wasn't enough tissue on it. So in this way, more tissue is preserved, that even if it is needed in future after 5 to 10 years, we still have the blocks available and the tissue available, and there is less chance of it being eaten away. The resection specimens, again, the oriented one, this is the schematic diagram from the Royal College of Pathologists. And we do follow these and the College of American Pathologists guidelines regarding the cutup of these specimen. Specimen is inked according to the sutures that are placed on the specimen. And again, you as a surgeon, you must be knowing that these outlines are arbitrary. So by the time the tissue is placed in the formalin, it becomes shrink and it changes its shape. So we try to sort of follow your guidelines regarding the sutures, and we try to put them in a way that it closely follows the sutures that you have marked us, and put our boundary lines of the superior or inferior or anterior posterior as close as possible. But again, as you know, these are arbitrary lines and we wholly solely rely on your marking of the specimen. And that's how the specimen is dissected and blocks are taken from it. This is the College of American checklist for the reporting of the routine excision specimen. We do write the procedure, specimen laterality, tumor size is very important, histological type. We follow the new WHO guideline, WHO classification for that. Grading is done depending upon their glandular differentiation, nuclear polymorphism, and mitotic activity. Ductal carcinoma cyto, if present, we do grade it and give size of it, and tell about the pattern of the ductal carcinoma in situ and necrosis. Then about the tumor extension, if it is extending up to the skin, nipple, or skeletal muscle. Margins, and then obviously the regional lymph nodes, micromets, macromets are separately described. And if the patient, as most of the cases, the surgery is done post therapy, so we do mention the therapy effect as well, and at the end the staging of it. Again, then these are the guidelines that we follow. These are up to date up till now. For the estrogen progesterone, the last guidelines came in 2020, and for the HER2 it came in 2018. This is again the proforma that we use for ERP HER2/neu. Now I will just briefly describe what we mean by all these terminologies. We just encircle whichever is correct for that particular patient and for that particular case. You can see a few words like 1 to 10% tumor cells with satisfactory internal control. I'll tell you briefly what we mean by internal control and external controls. External controls are the tissue that we put separately. This is the tissue that is supposed to be ER positive, and the tissue that is supposed to be ER negative. We check them in every batch, and if they are working appropriately, then we go ahead and report our estrogen receptor and progesterone receptor. But ASCO asks us that in addition to these external controls, we should always look for the internal controls. And what constitutes the internal control is the normal breast parenchyma that is present in the background. If that is ER positive, then that means the immuno is working appropriately on this tissue and the results of the ER are reliable. However, if ASCO requires us that if the internal control is not present, then it is better that we either check the external control if it's working, or in some cases it also requires us to if the internal control is not working, then we have to call it indeterminate. So in the reports, when you find that the ER estrogen receptors is indeterminate, it is just us basically conveying that although our external controls are working fine, the immunohistochemistry on this particular section or in this particular tissue is not working either, because there is any compromise in the pre-analytical factors, and the tissue is not optimal for the further studies on estrogen hormone receptors, and this might not be reliable. In such cases, it is better advised to either go back to the initial biopsy, or if any further tumor is present behind, then it's better to remove that and perform the immunohistochemistry there. Again, there's a special note for the tumors that have that show low 1 to 10% of ER expression by IHC. And this is the note that we give on our reports as well. And it is recommended by ASCO guidelines of 2020. It says that there is limited data on the overall benefit of endocrine therapies for the patient with low level 1 to 10% ER expression, but they currently suggest possible benefit. So patients are considered eligible for endocrine treatment. However, there are data suggested invasive cancer with these results are heterogeneous and in both behavior and biology, and often have gene expression profile more similar to the ER negative cancer. Some of the studies have cut it down to 1 to 5% as well. However, it is up to the oncologist's discretion how they want to take this case further. Right. From pathology point of view, there is a whole algorithm for cases that are 1 to 10% positive, that show 1 to 10% positive. So what we're supposed to do when we get a case which is showing 1 to 10% positivity is, first of all, we have to check that is the internal control appropriate. Secondly, we have to, if the internal control is appropriate, then that's fine. If there is no internal control present, then we check the external control. If they are working fine, that's fine. Then in some cases we repeat the ER again. If the results is same, then two pathologists have to look at it, and then it is reported as 1 to 10%. We are still reporting the PR because progesterone receptors was initially told, when I was working in NHS, most of the trusts there, they did not even perform the PR staining. They would only perform the PR staining if the ER was negative. However, in the recent 2020 guidelines, they say that the PR is more of a prognostic value now, that the tumors which are ER positive and PR negative behave adversely than as compared to the tumors that are ER and PR both positive. So PR has gone more of a prognostic value now rather than the therapeutic value. As I was telling you about the internal control, the picture on your extreme left is a positive ER staining. It is these brown staining the nuclei of the cells of the tumor. This is a good positive staining of the tumor. The middle picture shows that on the bottom of the picture, this is the normal breast parenchyma that is showing the good positivity of the ER, and on top of the picture there is a tumor which is negative. So this is a true negative tumor with good internal control, and these are reliable results. On the right with the star, this tumor is completely negative. However, there is no internal control present in it, and that's why we put a note at the bottom that no internal control are present, but external controls are appropriately positive. If needed testing, another specimen that contains internal control may be warranted for the confirmation of ER status. That is again recommended by ASCO. Again, HER2/neu IHC 0 to 3 plus, the top left is the 0, top right is the 1 plus, bottom left is 2 plus, and bottom right is 3 plus. Again, you see how the immunohistochemistry get affected by the tissue quality. The 2+ can easily become 1+ if the tissue quality is compromised, and unfortunately we cannot do anything about it because we have to interpret the HER2 guidelines according to the ESCO recommended guidelines, and if it does not fulfill the criteria, then we cannot call any HER2 2+, regardless of what the complete membranous staining or not. Again, you are all aware of the new HER2 guideline. They came in 2018 and now well implemented. The picture on the left shows the 2013 definition of IHC 2+, and picture on the right shows the definition that was recommended in 2018. Here they do not consider the strong staining as 2+, and it has to be weak to moderate and complete membranous staining of more than 10% tumor cells to call it IHC 2+. Again, previously, as you know, that HER2 FISH, there, even after performing FISH, there used to be an equivocal category where we could not say for surety that it is negative or positive. However, in the new guidelines, they have advised the pathologists how to go along with it, and eventually we have to give a result, either it is negative or positive. However, if we follow this criteria and if certain results come in our daily practice in the molecular testing that it is 2+, but the equivocal according to the last guidelines, then we perform all this procedure that is recommended, and if it comes out with a ratio of less than 2, more than 4 and less than 6 of copy signals, then we call it negative. However, we do add a comment that is given by ESCO to us. So now in this current situation, no HER2 goes out as equivocal after FISH studies. Cytological evaluation. Now this is a very important part of our daily practice, and as you know that cytological specimens are the most they're good for time, they're good for money, and easily affordable by the patients in government settings, easily done by the radiologist or the pathologist in the government settings, and it's like really easily available. However, with the breast specimens, as you know, if the clinical suspicion of malignancy is high, the core biopsy is always very valuable, because obviously we have to do all those tests on it, which we cannot perform on the cytological specimens. Having said that, still the role of cytology in determining the lymph node status of the patient and recurrence status of the patient remains invaluable. I'm actually very overwhelmed and very impressed by our colleagues at the periphery who are working with limited resources and who put so much effort to give so much care to the patient, and they put their personal time to handling the patients and learning such things. And I'm really very impressed by their struggle and really impressed by their professionalism. We were getting a few samples of cytology from a few government institutes, and they were going fine, and suddenly there was a drop in the adequacy criteria, adequacy of these samples. Again, as I said, I was very humbled, and I was really impressed when one of the performing radiologists contacted us, and they wanted to know that what is happening with the specimens, and we wanted to help as much as we can, and we asked them to just come and join us and let's observe our setup, just to see if there is anything, any step that is missing in their fixation of the slides that they were doing. As I said, it was really nice to see that a consultant came themselves and observed all the process and took notes of the things that they were doing different from ours, and they went back, and the last month we did an audit on it, and from that particular institute, now the adequacy rate is like 100%. We did not even decline one specimen based on the inadequacy of the specimen. So it's just the very minor things. And I do realize that you're working with very limited resources. And I really feel proud to be part of such a community of doctors which are giving their utmost to the patient, be it their time, be it their skills, be it their professionalism. And I really feel very proud, and I have a lot of respect for all the physicians who are working in the periphery and providing the best clinical care to the patients. So I've just, with that experience, I've just flow charted it, the very simple steps that needs to be followed to fix the slides that you prepare for the cytological examination. In this case, if you follow them, the chance of washing away of the specimen from the slides is very, very limited, because it's not always that technique of the taking the specimen that is lacking, but it is just about fixing of the slides that matters. And if you just do that, it will remove all the hassle of you doing the procedure on the same patient again and again. So it's not the skill of the radiologist that is compromised at this time. It's just handling of the slides that is being compromised. So when the specimen is immediately, whenever you do a pass, immediately make 2 to 4 slides, fix half of them in 95% ethanol immediately for 1 hour. And for the rest of the slides, just air dry them. If you do have a rapid stain, do rapid stain. If you don't have it, do not worry about that. Just air dry the slides and wrap them up and just send it to us, and we'll do that. We do have an on-site evaluation available, so it makes things easier for us at the department. However, if you do not have that, do not worry, and you can just go. In my experience, the on-site evaluation does take out a lot of hassle from the radiologist. What I have seen, even in one of the Royal Berkshire Trust, the radiologist used to have a microscope by his side, and he would just simply put the slide under it, and he will evaluate himself that, okay, is it sufficient or not, even before the pathologist would go there. So it was just very, just to be quick with the procedure and all that stuff. So, and he used to have a positive slide with him as well, just for the comparison. He will use the positive slide and see, okay, if this picture matches with that picture, then it means it's adequate. It's a very crude method, but it does help. It does help. PDL staining, the hot topic of today, and for today's management as well of the breast cancer. There's a lot of immunotherapy available, and as you know, recently, just a few days back, a new immunotherapy was showing good results in colorectal cancer of 18, which was done only on 18 patients, but they said that the cancer was removed in all of these patient. So the immunotherapy is really hot these days, and as hot it is, the thing is that it is rapidly changing. It is rapidly changing. As most of you know, that previously for the breast carcinomas, atezolizumab was recommended, and we were doing PD-L1 IHC-assay of Ventana SP142 on it. Even more than 1% was patient with showing more than 1% staining were eligible for the treatment. And the second one was of the DACO22C3 clone, which required combined positive score, and more than 10% was eligible for pembrolizumab. However, I've just and I'm sure you must be aware of it. I've just checked the website yesterday, and now this note is coming for atezolizumab that the indication of atezolizumab is a Tecentriq in combination with nab-paclitaxel chemotherapy as treatment for patient with triple negative breast cancer whose tumors express PD-L1 has been withdrawn by Roche. So you see that the thing is that these cutoff points, these criteria of which patient will get the drug and which will not, is rapidly changing in PD-L1. And we try to stay up to date with that. And because the process of marking the PD-L1 is very tedious. I'll show you in a minute. So we try to stay up to date with the cutoff points that they keep on, the FDA keep on issuing about these drugs, but they can be a bit delay in it depending upon how quickly it changes. So we always admire your input, and we always appreciate that you give us input, that what is your requirement and how do you want it to be. Initially, we were only giving the CPS and TPS score because there was so much confusion about the cutoffs. The company was giving different cutoffs, then FDA was giving different cutoffs. So initially, we did not used to say if it is a positive or a negative result. We will just put on the CPS score or TPS scores or IC scores, and it will be up to you which score you want to go with, which recommendations are you following, and you can treat your patient accordingly. However, when FDA has become a bit more organized in these PDL1 staining criteria, so we now try to put the positive, negative result for the cancers that FDA has approved. However, there is still list of the cancer which FDA has not approved. However, but we keep on getting the request for that. For those tumors, we just write that this tumor is not FDA approved, and you can follow your local guidelines. For pembrolizumab, the CPS score is more than 10. This is our proforma that we use for a 22C3 clone. As you said, that PDL expression result is either positive, negative, and the third line we have added is this test is not FDA approved for this cancer type. The scoring cutoffs are not well established. So you can just, if you're following a certain study, then you can score accordingly. For TPS, it is required that we do mention, is it less than 1%, 1 to 49, or more than 50. However, for the CPS, the benchmark is less than 1, 1 to 9, more than 10, and we have to specifically say that specific score is how much is the specific score. Adequacy, if there's a more than 100 viable tumor cells, then we say that yes, it is adequate. However, even if there are less than 100 viable tumor cells, it is recommended that you do the scoring, but in the end you just say that the viable tumor cells are less than 100, and it is up to the discretion of the oncologist if they want to go with the result or not. This is the scoring. As you can see, that a lot of time, and it takes a lot of time to actually count the cells, because we are still moving towards the digital pathology. In West, it all has gone digitalized. So it's easier for on that with artificial intelligence to count it. But however, we do it manually. The cells are being counted, the total number of tumor cells and immune cells which are positive, and they are with these formulas, we calculate the TPS and CPS score. Moving on, the BRCA mutation. Now the 2022 guidelines, NCCN guidelines clearly state that in metastatic setting, result from the genetic testing may have therapeutic implications. Germline mutation in BRCA1 to have proper clinical utility and therapeutic impact. Therefore, germline BRCA1/2 mutation should be assessed in all patients with recurrent or metastatic disease. And sample, we are performing these tests in Shaukat Khanum, and the sample that is needed for that is a blood sample. We have a biobank facility that we have recently started, and we are member of the Biobank and Cohort Building Network, International Agency of Research on Cancer, and WHO. Biobank is that it is only for the available for the in-house specimen, the surgery that is being performed in-house, because the specimen has to be taken before it is being put in the formalin. So far, 729 patients have been enrolled, and 564 patient samples have been collected. As I told you, that biobanking is done with consent of the patient, but the priority is the diagnostics. So if we think that the giving tissue to the biobank will compromise the diagnostics and then more tissue will not be available for our diagnostics and further testing, then we do not give the tissue to the biobanking. So by patient diagnostics is very important. At the moment, we are not giving away tissue for the research purposes. However, this is being closely monitored, and we check the tissue quality, RNA, DNA quality of the samples that we have stored. So once we are sure that the quality is maintained, so far the quality is being maintained and there is no issue in maintenance of the quality. However, if once it reaches the certain limit and we are assured that even after 1-2 years, the sample quality remains same, that we might be able to lend these specimens for the research purposes. Molecular testing. Again, the NCCN guidelines 22 have recommended these biomarkers for certain situations, not for everyone. PD-L1 again 22C3, BRCA I've already told you, PIK3CA, NTR-KMSC, and tumor molecular burden age through the NGS. Assays 21 gene oncotype, MammaPrint, Prosigna, and Endoprint, they are already in the market. However, their utility is still questionable. People are recommending it for different stages, but it's up to the discretion of oncologist. We do not have it at SKM at the moment. It's being done from the America. NGS, however, we do have NGS with us now. That is a good news. We have the machine and it is under the validation process. At the moment, this is a solid tumor panel test, hotspot V2, and these are the genes that it will be able to detect. It is for all solid organ tumors, and hopefully it will be beneficial. It will be available for the testing as soon as the validation is complete. So that is a good news. So I hope you are not disappointed with the quick and brief overview of all the updates that I have given you about the breast cancer pathology. In the end, I do understand that we do not have much of a contact with the outside clinicians as much as we have from the inside clinicians, because we do have every Friday breast MDT and the cases are discussed in that. And if anything new is coming up, we discuss with our clinicians right away and we are able to implement it. Unfortunately, we do not have that much direct connection with the outside oncologists and surgeons and radiologists. However, I would love to have the feedback of all of yours, and would love to have, if you have any suggestions, if you have any questions, if you have any queries, we like to have that have all of you on board as well. Right, I will just come to the questions now. Okay, Dr. Saud has come up that right. Dr. Saud has asked about the ischemia time and fixation time of outside specimens. Right. So what happens is that he has asked that for in-house it is easy to manage. However, for both these parameters are still reported for outside specimens, sometimes coming from far away where the communication isn't really possible. What do you suggest for them? So the purpose of this particular CMA is also that now as more surgeons are aware that this does make a difference. First of all, the good thing is that the most diagnostics and prognostic marker are being done on the small biopsies, core biopsies. For those, it is available. We know that it is minimum, and even if we have the time of the date of the surgery or the biopsy, we can calculate the fixation time. However, for the large specimens, then the purpose is to educate and re-educate. All they have to do is put the in their requisition form, they can just put the time the surgery was performed and the time the formalin was added to it, and we can do rest of the ischemia and fixation time calculations for them and put it on the report. However, as I said that in my personal experience, I do not report the ischemia time for outside specimens, but I try to put the fixation time for the outside specimens, because if the time of surgery is given, then you can do from that time, from that date to the time we start grossing, we can give the estimated time of fixation. So at least one parameter is followed in that. However, I do recommend that we do the cannot be determined category for those tumors, because it is not available.
Thank you very much, Dr. Mariam. It was very informative session. Thank you very much, everyone, for joining the session.